Thank you. So the general context, Aweil, South Sudan, MSF has pediatric IPD and obstetric activity. In the non-peak, there are about 165 beds, and this goes up to 320 in the peak. As you may know, in 2016, South Sudan suffered from active civil war, economic collapse, high malnutrition, and multiple epidemics. In Aweil, we face an exceptionally high malaria peak, which was patterned in the last few years. There's been a growing epidemic, or the peaks are much higher over the last few years, and you can see by the graph at the bottom. Our activities at MSF have also adapted over this last few years. In 2014, we had both IPD and OPD activities. In 2015, due to the presence of other actors, we only worked in the IPD, although we did have advocacy for the MOH and other actors at the country level. In 2016, we completely worked inside the IPD, but we also supported the OPD and had light outreach. However, with the unprecedented epidemic, what we found was that the other actors were absent. So in responding at the field, we had two hypotheses. Number one, that within the MSF hospital, we provided good care. And number two, we were highly concerned about the primary healthcare system, especially outside of Aweil town, and we had no systematic analysis to understand this. Our response included scaling up of our IPD activities, advocacy at all levels, and support for primary healthcare, although this was very delayed and happened at the end of the peak. There were three studies, epidemiology studies, around this peak. The first was a geographic description of patients inside our pediatric ICU done in the peak in August 2016. The second was a chart review of all children admitted with malaria in the MSF hospital for the 6 peak weeks. And the third was a population-based retrospective health-seeking behavior and mortality survey for the pediatric population of Aweil town and the rural areas. This was done in March 2017. In the first study, we reviewed all patients admitted to our ICU. What we found was that most cases were coming from outside Aweil town. And when we asked, we found the barriers to coming to the hospital included high transportation costs and a non-functioning ambulance system. The second survey was a chart review of all children admitted with malaria in the MSF hospital for the 6 peak weeks. The purpose was to determine whether there was a differential severity of condition and mortality from malaria in children coming from different areas. Overall, the hospital length of stay was 1.6 days for malaria, and the overall case fatality rate was 2.3%. When we mapped this, we find that the plurality of patients came from Aweil town, but in fact, they came from all the 5 counties of that area. When we specifically looked at the case fatality rates in Aweil town, Aweil East, and Aweil South, they were approximately the same, but in Aweil Center and in Aweil West, they were lower, while it was high in Aweil North. And now we have to remember that this survey was of patients who arrived to our hospital. So this didn't explain outside, and we as a team specifically asked for a population level survey. This was the retrospective health-seeking behavior and mortality survey done in March 2017. The purpose was to assess health-seeking behavior for malaria, the knowledge of malaria and malnutrition, and all-cause mortality for children less than 15 years old. The methodology was a retrospective, population-based household survey conducted in March 27 with the recall period from July 2016. There were 2 strata, urban and rural. This survey assessed the health-seeking behavior in over 2,800 households with children less than 15 years old, comprising of over 10,000 children. The results showed an under 5 crude mortality rate of 0.37 in Aweil town, and a much higher under 5 crude mortality rate in the rural population of 0.9. But when we specifically look at the 2 peak months of August and September last year, we find that the under 5 crude mortality rate reaches near the emergency threshold of 2. And then when we map this, specifically looking at the percentage of patients who seek care at our MSF hospital as the first choice, we find that in Aweil town itself, there's a high percentage, which makes sense. But what you can also see is that outside Aweil town, the MSF hospital is still a high percentage of first choice for patients seeking care for their children with malaria. And this may represent a lack of confidence in the primary healthcare system. So if we go back to our 2 hypotheses, that the MSF hospital provided good care, Well, the relatively low malaria case fatality rate inside our hospital at 2.3%, so maybe. And the second hypothesis, that we were missing a large epidemic and a large catastrophe outside of our hospital, what we find was that the under 5 crude mortality rate nearing 2 during August and September. And so the next sentence I want to say with a little bit of nuance is that under 5 crude mortality rate nearing 2 is very high, but it wasn't as high as we feared when we were presented in August and September, admitting over 100 children a day in our hospital. And the final point, I want to discuss a little bit about the 2017 planning for Aweil. So there's continuing to be advocacy at the field, capital, and headquarter levels. We will continue to work in the IPD with continued support of the OPD in Aweil town. An epidemiologist has been added to the team to help with real-time analysis. And for 2017, an emergency preparedness plan has been made. Near Aweil town, possibly if other actors aren't around, there may be 3 test and treat centers. And further from Aweil town, potentially supporting 4 to 5 OPDs. It should be noted that this emergency prepared plan was made in parallel to the health-seeking behavior, so was not influenced by it. Although as situation occurs, it could be adapted with the results from the health-seeking behavior. And finally, I'd like to thank all the following people, but specifically all the people who were in Aweil and helped with the epidemic last year. Thank you.